ask Michael Faloon now to give his presentation about combined or separate surgery for split cord malformation and scoliosis. Please.
Thank you. I was going to add one more thing to the end there, though it might be a little bit of a resource thing, but for congenital, a 3D model to have sterilized on the field during the case is just an excellent tool to be able to navigate your own self and to reorient yourself during the case as to distances and give yourself a great advantage, I think. But again, that's a resource that's difficult.
Yeah, I agree with you. In fact, we have in context of an research project, we do 3D reconstruction of deformities. We make models, absolutely one-to-one model, and you can sterilize them and you can have it on your table and you can basically have your model at your hand and what you have to do in your spine. I think this makes a lot of sense, in the complex deformities. I agree. Okay.
Try and share my screen. Am I up and running there?
Yes.
Okay, thank you. First, let me thank Dr. Zileli for the invitation. It's a little bit ironic, though, to be invited on a topic like this that I feel like some of the major knowledge is already in the room. And those people have to be acknowledged that I'll be presenting their research to them. You know who you are. And the one thing that this topic brought to my attention is that the vast knowledge that exists regarding the decisions to move forward with these treatments exists in very few centers and in the heads of very few people who, as time goes on, we lose that knowledge. In the United States, with things like abortion, we don't see this very much anymore. We only see it a lot of times through immigration and such cases like that, religious things. So we're losing that knowledge. And so I saw this as maybe an opportunity to possibly kickstart some of those minds that are here with putting together, the multivariable assessments for how to treat these cases. And I'll give an example of what I'm talking about. But so just quickly, to bring that example back is that Winter and McMaster have some of that knowledge that exists where we have these numbers that no one is really reproducing or showing on the grand stage with papers because the volume is so low. But in terms of
can you make image whole page? Thank you.
You can.
Yeah, there we go.
Yeah,
I got it.
perfect.
Okay. Sorry. So 30% of all congenital cases have intraspinal anomalies, and of those, 2/3 are split cord. These tend to be part of the most severe of the curves that exist, according to the initial epidemiology studies. And so, as I was saying, with regards to classification of early onset scoliosis, this paper set to look at what are those multivariables that affect our decision making in the treatment process of these patients. And split cord should fall into its own separate category for this decision making in terms of trying to define what the treatment regimen should be. So breaking it down, whether or not or how you make your decision on single stage versus dual stage, the patient factors that are there and then the surgical factors are there in terms of what are you going to do. So some of these multivariates should be age, the hemodynamics of the patient, the bone morphology of the actual pathology itself, cord status, and curve magnitude, as well as risk of progression. I think some of these and within these are the factors that should be looked at. And then the surgical factors. Are you doing resections? How many? What are the osteotomies? What type? What is your fusion plan? Short? Is it long? What is the blood loss at the time? What is your OR time? And certain things and factors like having 2 attending surgeons have been shown to have an effect on things such as OR time. So this is a nice paper that looked at congenital scoliosis and operative treatments. And the patient factors that we have to look about are, what are the comorbidities that these patients have that affect our operative experience? And what's very notable about these patients is we know that they do have a great amount of cardiac and pulmonary anomalies that lead to and affect cardiopulmonary function. The study showed that every single one of the congenital cases showed a great risk with decreased FEV1s, decreased vital capacities, and overall cardiac function. I bring this paper out not as a self plug, but I think it answered one of the questions that was posed before. We were forced to kind of change the title of this, and I really was proud of this paper in terms of, we looked at all of the papers that were published, and there's 18 very good papers on MRIs preoperatively on patients undergoing AIS fusion procedures. So it included almost 5,000 patients, and the overall ratio is 8% of those who have been diagnosed as AIS when MRIs are done preoperatively demonstrate some kind of neuroaxial anomaly. And I feel like the fact that our title gets overlooked in the fact that we published this and it's been out there, and 33% of those end up having neurosurgical consultation and treatment. So other patient factors, and in terms of how is this going to affect, is the type itself, the bony anomaly, the type 1 classic, which has the bony ridging and the separation, versus the same dural sac and possible phylum. Another important factor that I think should be looked at in your decision making is the Lanky classification of looking at, again, very simple but very important, is what is the status of the spinal cord prior to the procedure itself? What is the morphology of it? And type 3 anomalies that demonstrate flattening or deformity of the cord itself on some kind of apical or concave pedicle or bony surface with no CSF surrounding more than half of the cord, are 28 times more likely to have an intraoperative event on monitoring during the case. And that's I think significant. That should be included in the classification. When switching, and in direct line with that, is what are the planned osteotomies? In my hands, typically I like to instrument my preoperative plan and get all smaller resections, etc., done first. Maybe not place a rod and do correction, but save the osteotomy for a time where I decide, can I proceed or not? Dr. Bawachi used to say that's the decision-making time, is when you're about to do the osteotomy. And what I can say is that it's nice to maybe go in, loosen up the spine, place your instruments, close everything up, put in a temporary rod, possibly put a patient into halo gravity traction post-operatively, give them some time, and then come back and do a single-staged procedure where the second stage of the procedure is just the osteotomy, where you're coming in fresh, first thing in the morning, etc. We all know that PVCRs, etc., and in our small group, we take the procedure, we take the patient factors, and we need to multiply what the intrinsic rates of what we're doing are for the risk of neurologic issues. So VCRs themselves, we know, have a significant risk itself that needs to be multiplied by the patient risk. Back to the bony anatomy is, looking at the acuity of the curve. The deformity angular ratio has been shown in several papers to be one of the highest predictive values of having a neuromonitoring event intraoperatively. This goes back to where the spinal cord is. They're a little intrinsically related, but you can cause new neurologic deficits based on that ratio being higher or lower. And in this series, they demonstrated that the DAR, the angular ratio or the acuity, was more important than the procedures itself or the overall magnitudes. And signal losses occurred when those values were significantly high, greater than 27, you can see there. Also, back to surgical planning, there's an intrinsic risk. If you have a short segment, very long, or I'm sorry, if you have a short angular deformity and you have a long curve that's sweeping, I'm a big fan of internal distraction. Internal distraction has an intrinsic rate of significant intraoperative events. Lastly, just to throw this in there, we have to throw operative time into the equation and look at what our risk for secondary issues of complications like infections, etc., have to do with our planned procedure of staging versus not staging. That decision you get to hour number 7 and you realize how much more time you have left. I think intraoperatively you have to be ready to change your plan. Although in this paper here, which I think is a very nice one, looking at what the consensuses are, intraoperative time was not included in that, but this is what I would think we would be looking at by talking about the split cord plan. This is the deciding factor. Should you do a stage? Should you not do the stage? I think you make your plan preoperatively, but everything that we do in the OR is going to be driven by what the checklist is for if we have or don't have an intraoperative neurological monitoring event. And if there's anything that determines that more, it's going to be responsive to this system and neural monitoring. I know that speaking to my mentors, that this has been the game changer in allowing us to do this with significantly decreased complication rates. And it's almost like we overlook it to some extent now as we talk about this, but this is the driving factor, staging or not staging, and what those consensuses are. So again, ironically, I decided that the first outlook was written about doing safe non-stage procedures is only 2007, and it's by those in attendance. So they showed that it was safe, that it's well thought out, and if the plan goes to plan, then it's a viable option. I think it's also acknowledged too, though, that we need to look at 9.5 hours of surgery. Are there ways to shorten that? Should we stage it at that point? And are we creating new neurologic deficits, etc.? That's intrinsic to the operation itself or not. But this is our starting point for even looking forward. And again, this was different than the classic approach at the time, which would be to do the neurosurgical event first and then go back and do the correction. And Dr. Ezeki just presented this, and I was actually hoping that maybe you would just keep going so I could learn something while you were giving your talk, because clearly the experience is there with that. And separating again type 1s versus type 2s, excellent demonstration that type 1s might have a more intrinsically and obviously resecting that a rate of increase in complication rate versus type 2s, which is going through with correction. This is a paper that then came out demonstrating corrective surgery without the resection at all. Sometimes when people report that they have no neurologic deficits with these type procedures, I have to maybe question it a little bit. But they had 214 patients, type 1 versus type 2, didn't perform any resections, and didn't have any neurologic deficits. It's in JBJS, so it went through a very extensive review, I'm sure. But that's a lot of patients to not have a single neurologic deficit. This is a patient. This is a paper that sums everything up fairly well in terms. It's published in 21, but it brings together. It did an excellent review of the staging and non-staging literature from 2010 on. In and of itself, also they looked at their own series and pooled the majority of the data with the publications that they had. To obviously in increasing the magnitude of what they could say. They assessed 214 different articles within this, basically got down to 9, and obvious statements were that things like blood loss is increased with non-staged operative time, but more importantly, the complication rate was more significant in the literature with a single staged event. Now, again, that's encompassing all procedures that underwent a single stage. And again, the importance for us is to figure out the particulates and weed out why and who are those 28. But that's a significant difference in complication rates between the two. So obviously, it's not indicated in all cases. And I think some of the consensus that are coming out is that type 2s, more recently, the literature focuses on a single stage. The type 1 is where many more of the complications lie and where the variables occur. And then I do add in there, things like halo gravity traction. When does that come into our planning process for staging this procedure or not? There's the option for the preoperative halo gravity traction, which increases things like pulmonary function, the ability to decrease intra-abdominal pressures and optimize patients with nutrition, loosen up the spine itself. Again, that's not applicable when we look at age. If you're talking about a 3-year-old, that may not be what we're looking at for a 9-year-old. So all in all, intraoperative neuromonitoring is really what drives us in our decision making for our plan. What do we plan on doing? Are we going to do 1 stage or 2 stage? What kind of resections are we going to do, et cetera? What am I going to do intraoperatively? But I'm obviously limited by the patient itself and their variables. So putting this together, the patient factors, the surgical factors, in order to drive more of a not classification, but at least a working decision-making tree. I think the experts need to break down the factors involved here for that decision-making tree. So thank you very much.
Thank you. Thank you very much, Dr. Faloon. This is a very comprehensive summary of the available literature today and what has been collected over time by specialized centers. As I mentioned earlier this afternoon, all these issues are very specific for people who deal with this rare pathology of congenital scoliosis. I can tell you in Switzerland, we see maybe in the 5 university hospitals in Switzerland per year, congenital scoliosis to be operated on. Maybe these are maximum 10 cases a year. Whereas you go in areas like, I assume in Turkey, I work a lot in Pakistan, in Armenia, where you have in one consultation, you have 20 patients. So, the average guy in the so-called industrialized countries, they don't really see these patients. And you are absolutely right. I think there is so much knowledge from areas where this pathology is really present, that it would be in a way times that they put this knowledge together, because I mean, even a resident or a fellow in a spine unit in our country, he probably sees that very rarely, you know. So that we have to be aware of.
Yeah, there's a little bit of irony in it that again, you know, like in the United States, obviously we have great technology, et cetera, but not all of our surgeons have that knowledge. And some people end up leaving a country where honestly they've got strong opinions and strong knowledge and outcome and follow-ups, and they may end up getting somebody over here who has seen a couple, you know.
Yes, you're absolutely right. Any questions, any comments from the participants? Yes. Do we have any questions here? No, I don't have. Any questions from the faculty? Comments? So I think if there is no questions, no other comments, I think we are already time-wise pretty much out of shape, but it doesn't matter. It's very interesting. I hope this is really this is not the problem. So I may ask.
Sorry, I can ask both speakers, Michael and Muharrem, and also Yahya, but what is your attitude now? Do you make in staged surgery if there is a low conus or tethered cord, or in one surgery? What is
May I-
your what
Yeah,
is your
I
general
can
policy?
okay, I can start. And over the probably in the 20 years, we do the neurosurgical, if it's an indicated neurosurgical intervention, we do the same stages. I mean, the neurosurgical colleagues start their job first, and they finish. And as we are sure the neuromonitoring is okay, no problem, we can continue our job. The reason for this, one is time consuming. Second, it's all the length marks, it's still clear. If you perform the neurosurgical procedure and deformity surgery in the two different setup, and the deformity, at the time of the deformity surgery, it's even exposure, and placing the pedicle screw is more difficult than in the first stage. In our daily practice, we always do simultaneous sequential, and the neurosurgical colleagues start first, and then we check all the motor and sensory signals is okay, and we can go forward.
Thank you. Michael?
Yeah, again, the only from my perspective, again, so exactly as was just stated is the thought process. I do like the instrumentation prior to the type of osteotomy, and the resection is something though that I do like to save for last, because I'd like to achieve as much as possible in terms of the planned procedure in the first stage, and sometimes return to the osteotomy as its own kind of event. So in other words, there's very variable in terms of what we're talking, but in other words, go in, expose, instrument, and then see what time you have before performing a VCR or you can always temporary rod. You can always return the patient back to the floor and then plan out the osteotomy time. You may even get more correction if you have them with a halo gravity traction on, and you may have a better outcome with that. You can increase their nutrition. You can get them ready for the osteotomy and the big blood loss. You also don't want to be doing an osteotomy at 6 p.m.
Yeah, this is a great point. Just one the extra comment. Even we plan to stage the surgery, in those cases, we put in the arpentical screws in the proper places and then close the wounds to make everything is ready for second stage. I mean, the neurosurgical procedure is usually, not usually, is always not creates any instability. Don't worry about to making the spine is unstable. But even you have a plan for staging surgery because of time issue, because of bleeding, because of vital signs, I mean, the instability. Even in those cases, the placement of the pedicle screw it would be great for second stage. It makes your job is easy. Definitely agree.
Great.
We are
Thank
the
you.
same. We are the same. In neurosurgical procedure, for example, in tattered cord or split cord malformation, we make small incision first. We release the tattered cord, and then we check the neuromotor. After that, we start scoliosis operations. And in the stage operation is different. For example, in congenital scoliosis for rigid angles need to take long time for osteotomies. Professor Yazıcı said the same. We placement the pedicles and we close to the wounds. Then 4 days or 5 days later, we open again, we make osteotomy and we correct the deformity. But for neurological procedures, we make one stage.
I think we can pack up to this webinar. Max, would you like to tell something?
Oh, I would like to thank the speakers for their quite impressive talks. You know, there is a lot of knowledge which has been shown to us. It's almost too much to get in one shot, you know. As I said before, it's very important knowledge for people who deal with this kind of pathology. There are certainly spine surgeons who don't see this pathology, but if you see it, it's very helpful to have this knowledge which we just exposed during this webinar. So for me, I always learn. Also, I have done quite a few of these things, but it's great. Thank you very much for organizing that.
I also thank all the speakers for their valuable lectures and then very nice discussion. Goodbye, everybody.
Thank you.
Thank
Thank you. Bye-bye.
Thank you.
Thank you.
Goodbye.